Please welcome moderators, Drs. Coy Tan and Laura Snyder.
Hi, welcome to our MIS session this morning. We're excited to have here a wide range of speakers to talk to you about MIS performance best practices today. We're going to start out this session with Philip Louie, who will be speaking with us about MIS classification and what's out there now.
All right, thanks everyone. Thanks to the committee for this wonderful session. Phil Louie here. I'm an orthopedic spine surgeon out in Seattle at Virginia Mason. And so we'll be talking today about sort of MIS classification systems and what's out there now. There are my disclosures. The ultimate answer, I'll just jump to my conclusion, is, well, there's actually not a whole lot. So then we have to dive into this. Well, why not, right? Why don't we hear or talk about a lot of these classification systems if they don't exist? Well, what do we currently have if there's not much out there? And what do we need in order to build classification systems that we can use reproducibly and that can be universally accepted? So if we take a step back and look at classification systems as a whole, right, why are they so important, right? These are essential tools because they allow us to effectively communicate with each other. Right, if you remember being a junior resident and you're on call and trying to tell your attending surgeon what actually came in through the trauma bay or the ED, you used a classification system at times because it was the fastest and most efficient and maybe the most effective way to present that initial pathology. But also provides outlines and algorithms for us to eventually provide evidence-based management for our patients. And so if we look at MIS surgery in general, right, you've got the complexity of surgical pathology and the resultant techniques that sort of fall into this umbrella of MIS, but they're becoming more disparate over time. And so the need for these classification systems are becoming more apparent. But some of the difficulty we face is, well, what do we even mean by minimally invasive surgery? And, if we talk about classifying something, right, it's really hard to classify something that is really not well defined to start with. So if we think about, okay, well, what is minimally invasive spine surgery? And that becomes a tricky question. And I think the definition ultimately varies depending on who you ask. But sometimes I think some people sum it up better than others. So if you look at Supreme Court Justice Potter Stewart, when it was trying to define pornography, I think that's often how we define minimally invasive surgery as well, right? It says, I shall not today attempt further to define the kinds of material I understand to be embraced within that shorthand description, and perhaps I could never succeed in intelligibly doing so, but I just know it when I see it. And most surgical subspecialties have embraced this sort of minimalist concept, right? There's a basic tenet of surgery, right? We try to effectively treat pathology, and by trying to do this with minimal disturbance of the normal anatomy, right? You're trying to leave the smallest footprint. Smaller incisions, less soft tissue disruption, and limited surgical corridors. And so if you do a Google search, I don't know if we can turn off the volume there at all. If we do a Google search of classification systems and minimally invasive spine surgery, there's just not a whole lot out there. There's a single study there that we'll discuss in a little bit, but otherwise, even in a broad Google search, there's really nothing to be found in trying to effectively communicate a classification system on this type of topic. And so if we look back at what's actually been produced and published in literature, I think one of the initial attempts at describing MIS techniques and then throwing out their classification system was by Dr. Vaccaro's team in 2007, right? And this is when sort of minimally invasive as a coined term was probably more near its infancy at the time. And they divided these surgeries into 4 specific categories, right? One being percutaneous procedures, the second being sort of these endoscopic or thoracoscopic or laparoscopic procedures, surgery through a tube, and, well, a minimum incision procedure, whatever that may be. But that was back in 2007, and that may not seem that long ago, but that's been 17 years now. And we ask ourselves, what happened in 2007? The first iPhone came out, Netflix just became a company and was renting out hard DVDs, the Kindle had just come out, and Twitter, which doesn't even exist in its current form anymore, was in its first year. So lots happened since then. So maybe if we aren't doing a great job performing classification systems in MIS, sort of that spectrum, well, let's look at our deformity colleagues who have actually done a wonderful job in creating classification systems. Because, if we think about MIS surgery these days, we often think about, well, how do we think through it from a lens of a deformity surgeon as well? Because, these surgeons may claim that whether we like it or not, everything we're doing is a deformity operation, and whether we're correcting a deformity, preventing one, or creating one, even with our minimal footprint surgeries. And so Praveen's team, this is back in 2014, about a decade ago, well, let's take the adult deformity world and apply the MIS principles. And what they came up with is this wonderful algorithm that looked at creating this framework for rational decision making when considering an MIS versus open procedure in adult spinal deformity. And it's really based on the radiographic presentation and the sagittal alignment in which the patient presents with and the flexibility of the curve. And they were able to define various procedures that fall into buckets on how to best address that pathology, either using a minimally invasive footprint or those techniques at the time versus the traditional open techniques. There have been a couple other attempts at creating classification systems, albeit a bit broadly, and a lot of these occurred around the same time in 2014. This is a group out of Shanghai that classified lumbar stenosis into different categories in terms of the pathology itself, and then trying to apply various MIS techniques, whatever those may be, to address the classified lumbar stenosis presentation. In that same year, there was another classification of minimally invasive techniques, but for intraspinal lesions, and the location of that pathology as well, and what types of minimally invasive techniques can be used to address that pathology depending on the location of that lesion. So then we kind of take a step back, right? If we're having trouble trying to create a classification system, what's actually important in a classification for MIS techniques? Well, there's invasiveness, which is a bit of a nebulous term at times, but that's sort of the topic of the next talk in the session. Well, how about the approach? And then there's, well, what do patients care about? We know patients often want a minimally invasive procedure, so what do they care about in these sorts of techniques? And I think that aside from a surgery that is effective and actually improves their pathology, right, can we create a classification system that helps predict the postoperative course in patients that are undergoing surgeries? And maybe let's start with a more basic surgery like a laminectomy or a decompression that can be performed in various different ways, taking into account the type of surgery being performed and the approach in which the surgery is being performed. So that's what we did a couple years ago with Shiraz Qureshi and the HSS team, is we tried to create this classification system looking at predicting and understanding the postoperative course when undergoing various surgical techniques. And the way we thought about it was this. Well, if we think about the major goals of a minimally invasive approach in the spine, it was, well, let's try to limit iatrogenic soft tissue injuries. Let's try to reduce perioperative morbidity. And we want to get patients back to recovery and back to the activities they want to do. And we thought, well, okay, two of the most important outcomes may be postoperative pain scores and length of stay. So when we use postoperative pain scores and length of stay as the primary outcomes, we developed this classification system with 6 different levels, looking at the type of surgery that's being performed from a decompression to a fusion. And as you can see on those top 2 lines, the number of levels of which was being performed, as well as the number of approaches that were taken to achieve that surgery. Again, we looked at a lot of other perioperative and acute postoperative outcomes focused on postoperative recovery, but we created this classification mostly based on the 24-hour oral morphine equivalent requirement, as well as the length of stay after these procedures. And I think at this point what we're seeing is a lot of these spine societies are working on this. And so we can stay tuned at this point because there's a huge push into trying to understand, well, how do we best classify these minimally invasive procedures? I know Dr. Hartle and his team are working heavily with the AO spine right now, and they're getting close to a large classification system as well that try to broadly encompasses everything that we've talked about today. And so I think at the end of the day, yes, an MIS classification would be really, really helpful. But we need to figure out a few things still, right? One, what's the goal of what we're trying to accomplish with a classification system? How do we actually use it? And how do we adapt it to a dynamic nature of this field? If spine surgery is always changing, how does the classification adapt to the changes in our techniques and the patients that we're treating? And then how do we best define invasiveness? Thank you.